Our speaker right now is Deborah Lipson. Deborah is a pediatric pulmonologist at Community Medical Center in Missoula. She's an association clinical professor at CU School of Medicine and UW School of Medicine, as well as associate research professor at University of Montana. Please welcome Deborah Lipson.
Now it has a green light on. All right. There we go. So thank you guys so much for having me. I'm one of two pediatric pulmonologists in the state. The other one is Dr. Lysinger in Billings. And I work very closely with a variety of different speech pathologists. And so I'm very grateful for you guys in terms of how you can help me and all of my patients. I have a clinical appointments at University of Washington School of Medicine and University of Colorado School of Medicine. And then part of my salary comes from the University of Montana here. In terms of my other disclosures, I do write some chapters for textbooks, including Kendig's and Nelson's, which are pediatrics and pediatric pulmonary textbooks. In terms of what I'm going to talk about today, I have cases, and more cases, because I figured those were going to be the most interesting. We'll have a brief interlude on spirometry, and then I will talk about my medical approach to chronic cough patients as well. All right, so here's my first patient. And so some of these cases I have taken from presentations I've given previously about patients with a variety of pulmonary speech overlap issues. And then I've also had something like 5 to 10 patients in the last 2 or 3 weeks that I've also snuck into the presentation or an amalgamation of their cases. So this patient I saw about a week and a half ago. She's a 14-year-old female. She feels like she's had shortness of breath her entire life. She feels like she can't get a full breath. She has difficulty getting air in. From a social history perspective, she was recently removed from her bio parents and is now living with her maternal grandmother. When she was with her bio parents, they had no running water or sewer. Her bio parents used drugs, and she was not placed in school during that time. She does have anxiety attacks with difficulty breathing, and I can't remember off the top of my head if we teased out, is it that you have trouble breathing and then you have anxiety, or is it that you have anxiety and then you have trouble breathing? She did lung function tests, and they were normal, and she had a chest radiograph, and that was normal. So, what are your next steps in the management of this patient? And happy to just give the answers. And I will tell you that because I'm here, 90% of the time, it is going to be refer to speech therapy. So I referred her to speech therapy. I don't think she's actually been evaluated yet. Another patient I saw on the same day who had a very similar presentation saw speech already, and the speech therapist who's seeing them said, 14 and 15-year-old girls are the hardest patients that she has to deal with. We will talk about what she has in when we go through this next case. So this is a 15-year-old swimmer. She is a straight A student. She's a state-level swimmer. She has a history of asthma since she was little. She's been taking daily albuterol despite being on a controller medicine for her asthma. Her exam was completely unremarkable. She had pulmonary function tests. They were normal. And then this is hopefully a video of her swimming. And I don't know how to give you sound on this. Anyone know? Let's turn sound up. Oh, goody. Well, so I get to do the sound for the videos. And so she is swimming to the edge of the pool. She's having a lot of difficulty when she's breathing in. And so she basically sounds like this. So, again, what are your next steps in the management of this patient? What is the answer going to be? Refer to speech therapy. Yay. So she's got vocal cord dysfunction, which is also now known as inducible laryngeal obstruction. The ICD codes are the same for both. And when explaining to parents, I will say that I am guilty of still using the words vocal cord dysfunction because I think those are closer to a 6th grade level than inducible laryngeal obstruction, which is not close to a 6th grade level, which is what we are supposed to be using for family education. So vocal cord dysfunction is most common in high-achieving teenage girls. And what I describe to the family is your vocal cords are sitting at the top of your airway, and one of their jobs is to protect your airway. One of them is obviously to help you talk, but the other one is to close to protect your airway from stuff getting into your lungs. So when you swallow, they slam shut, and you swallow, stuff goes into your stomach and not in your lungs. Sometimes I describe that your vocal cords sense that something is trying to get into your lungs, and so they start closing, and it makes it really hard to breathe in. And biggest triggers for patients are exercise, cold air. So you do exercise in cold air, and that is a double whammy. So Nordic skiers, cross-country runners, especially in fall, are very common. Reflux can be a trigger, and stress and strong smells. And so you can sometimes get a sense of what their triggers are when they come into the room. So they come in, and like this first patient, she's a swimmer, she's having trouble with her swim meets, and so she, for her, it's an exercise issue, the increased airflow going past those vocal cords. Sometimes you have kids who walk into the room and their shoulders are up, and you're just stressed out sitting in the room with her. I have one patient, he's getting his pulmonary function test today, who family swears up and down that is not vocal cord dysfunction, and I swear up and down that it is not asthma. And I've got him on all the asthma medicines, and he is so anxious he can't do the pulmonary function test, so I can't prove to them that it's not asthma. Stress, anxiety can definitely be a big player. Strong smells, so sometimes people will describe every time they go into Sephora, they have an asthma attack, and it's really a vocal cord dysfunction attack. So this video is very dramatic. So this is a boy. We do see it in boys. I would say a lot of my patients that I've seen here have been boys, at least 50-50, which is unusual. I don't know how much COVID has changed all of that. So anyway, this is a boy. Let's see if I can go back to the beginning. So he's a boy. This is the gold standard for diagnosing vocal cord dysfunction or inducible laryngeal obstruction. You do an exercise challenge test. It also helps me rule out asthma as well when we do combine it with spirometry. So he's running on the treadmill. He sounds like this. It's really hard to do. You can see he looks like he's about to collapse. He's having a lot of distress. So this kid feels like he can't breathe. He's super anxious. And so we make him run on a treadmill so that he can't breathe. And then we shove him in a chair, put some lidocaine up his nose, and then we shove a scope in his nose. And that doesn't help him breathe any better. So here they are putting the scope in his nose. I will tell you that right now, his breathing is completely quiet. So the act of waiting until after they've gotten off the treadmill, sometimes you can completely miss that they're having inducible laryngeal obstruction. Fortunately, if you could hear this guy, so again, you can see he's working hard to breathe, he's using extra muscles, he is having stridor again, and you can see his vocal cords closing. And we might watch that one more time. So I have ordered this test maybe once. I hate it. I absolutely, absolutely hate it because I think it's cruel and unusual punishment for everyone involved. And I'm just gonna play it one more time so you can see his vocal cords moving that time. So one of my friends has gotten puked on when she stuck the scope in the patient. A lot of times if their stridor is already gone, you've missed it, and so you can't actually see anything. And so you could say, yep, you had vocal cord dysfunction, but now it's better, yay! And you take this anxious kid who feels like they can't breathe and shove something in their nose, and it just makes them feel even worse. So I hate it, and I don't order it, but this is available and out there. What I do find useful is when I have kids where I'm having trouble teasing out, is it inducible laryngeal obstruction or is it asthma, or both? I will do the exercise test where we can hear if they develop stridor. And And then we do spirometry afterwards to see if they have a drop in their lung function. We'll look at one of those exercise challenge tests in a little bit. And we actually did one yesterday. So we're just gonna zoom in to the camera, and you can see the vocal cords are adducting as he's breathing in, which you can't tell, and he's having stridor at this, as that's happening. All right, so back to that 15-year-old swimmer. So you already knew that the right answer was we're gonna send her to speech therapy. You also wanna think about treating their underlying triggers. So if stress is a big component, getting them into counseling. And so the way that I usually frame it is that stress can sometimes cause vocal cord dysfunction or inducible laryngeal obstruction. And I will write both on my instructions just because I want the correct term on there, but also the one that is more understandable. And so I say that stress can be a trigger, but also feeling like you can't breathe is really stressful. And so sometimes talking to someone about that. And so that kind of takes the stigma of, I need to go to counseling because I'm stressed out. It's more, I feel like I can't breathe, and that's really stressful. And so I go. I don't know if that actually helps families, but that has been my approach. If reflux seems to be a big trigger, then treating them with anti-reflux therapy. Avoidance, so it's not necessarily that you want to avoid the trigger, it's more that you want to find ways to manage it. So whether it is when you're going out in cold air, you're wearing a scarf or a neck warmer, and you're practicing the wonderful exercises that you guys teach. If it's strong smells or smoke, I mean, here on the really smoky days, I don't know that I can fix that, but some days you're going to be better off being inside, but also just practicing your exercises. So avoidance is usually the very last thing that we want to do until we can really get those symptoms under control. So just some take-home points from these first two cases. So vocal cord dysfunction is very common. The key history findings are patients who present with difficulty getting air in rather than getting air out. They're wheezing when they're breathing in. And what I will say is that, so the sound that they make with vocal cord dysfunction we call stridor, whereas wheeze is a polyphonic sound that's coming from the lower airways. Patients will describe a feeling of tightness, and when you ask them where it is, it's usually up here. It can be in the upper chest, so it is not exclusively in the throat, but a lot of times when you ask, they'll describe that they have tightness in their throat, and that's usually surprising to the parents. These patients feel like they're gonna die. I've seen patients come into the emergency department, I've seen them get epinephrine for a horrible asthma attack, I've seen them get intubated. So these are very, very scary patients to see when they're having an acute attack. The other difference between this and asthma is that the symptom onset with vocal cord dysfunction or inducible laryngeal obstruction is very fast. So it's usually within the first 5 or so minutes of exercise, for example, with exercise, whereas asthma will take about 20 minutes for you to develop symptoms. So sometimes my patients, like the kid that I saw yesterday in clinic, it was a little hard to tease out. He's like, I have trouble breathing in, I feel tight here. And I was like, here, can be either. What else was it? Oh, it takes him 20 minutes to develop symptoms. And I was like, well, 20 minutes, that's more of the asthma thing, but maybe it's that you're just not pushing yourself at the beginning. So sometimes it can be kind of hard to tease out. But we stuck him on a treadmill yesterday, and he started having stridor, and we did pulmonary function tests, and they were totally normal. All right, so here is another patient. So this is a 10-year-old male. He had 2 specific episodes that triggered them to come and see me. So he had to sleep in his parents' room because guests were staying in his room. He woke up in the middle of the night and then felt like he couldn't breathe. He had noisy breathing, which they described as perfectly as stridor. He took mom's albuterol without a spacer, which you need a spacer for it to get into your lungs and not the back of your throat. Albuterol didn't help, although he wasn't taking it correctly. He was panicking, and then they brought him into the ER, and he was completely fine by the time they got there. Another day, he was scootering to school, and it was really cold out, and he felt like he couldn't breathe. He felt tightness in his throat and not in his lungs, and he actually said the words, I was tight in my vocals, and he had difficulty breathing in only. So here we go again. What are your next steps in the management of this patient? And we're going to send him to speech therapy. He has also got inducible laryngeal obstruction. All right, so this is an 18-month-old male, and what I will say is, so these are all based on real, actual patients. We do see more respiratory pathology in younger males than we do younger females. So we see more asthma, bronchiolitis, croup, airway malacia, floppy airways in the younger boys than we do in the younger girls. And then at puberty, we see more asthma in girls. And so I haven't actually looked at the number of males and females. It just feels like I so far got a lot of males, but these are actually based on real cases, and we do see more pathology in younger males. So this is an 18-month-old male. He's been coughing for a month. He was admitted to the hospital, was sick, had cough, fever, hypoxemia, was diagnosed with bronchiolitis, and discharged home on oxygen. He kept coughing when he saw his pediatrician. He was coughing all day and all night. His cough was dry, and nothing seemed to help his cough. They tried albuterol and cold air and honey. They did a chest x-ray that maybe had an infiltrate, and no exciting past medical history, surgical history, family history. On exam, he was active and playful. His oxygen saturations in room air were 90%, so much lower than we would expect. His weight was less than the 3rd percentile, whereas previously he'd been 15%. So he was growing well, and then all of a sudden he fell off his weight chart. He had decreased breath sounds on the right, no crackles, wheezes, prolonged expiratory phase to suggest asthma or pneumonia. His trachea was midline. He had no clubbing or adenopathy to suggest some kind of underlying disease process. So this one, speech therapy is not the answer, but it is something that we see very commonly, and so I figured I would throw this one in there because it could potentially be life-threatening. And so the answer is, with this one, you are doing both 1 and 4, so we're sending him to the ER to look for a foreign body. And so what they do is they do 2-view x-rays, and so they either do when they breathe in and breathe out, or they do frontal view and then on the side. And what you can see is that this lung is, so this is the frontal view, so just straight on, and you've got a right lung and a left lung, and then when you put the right lung down, it should be collapsing, but it is just as big as it was before. And that is because when you look inside his airway, he's got a thing there. I don't remember what this thing in particular was, but we see foreign bodies all the time, especially in the toddlers who stick everything in their mouths. You remove the foreign body and the airway is angry, but will heal over time. So you never know if there's a foreign body unless you actually look. You want to look sooner rather than later. And if there is a history of choking on something and then having a prolonged cough, if you have crackles or wheezes just on one side and or chest x-ray findings that would be consistent with a foreign body, then somebody needs to look. So I include these because they're kind of fun patients to see, and it's very satisfying. These ones theoretically are not coming to you, but so this was a 14-year-old girl that we saw who had recurrent pneumonias, and it was always in the same exact spot in her lungs. They went in, they did a bronchoscopy, and pus just poured out of there. They did lots of airway clearance, pounding on her chest, antibiotics. To get the mucus out, she had bronchiectasis or scarring in the airways, and because she kept getting pneumonias, even with all of those treatments, they ended up taking out her lung, and right in there is a flip-flop tag from her flip-flops from about 3 years ago. So she was chewing on her flip-flop tag, and she breathed in, and she got her flip-flop tag stuck in her lungs, and then she had lots of pneumonias after that. So the moral of the story is, don't forget about foreign bodies, and don't chew on your flip-flops, I suppose. So this is, I will tell you that this is the one, I believe this is the only patient where we do not refer to speech therapy. So here is a 14-year-old female. She's been coughing for 8 months. She was diagnosed with pertussis when it all started. Albuterol currently helps for 15 minutes. She coughs during the day, but when she is asleep, there's no coughing. Her cough is worse with practice. I think she was a swimmer too. I'm trying to remember. And so she starts coughing with practice, and then she keeps coughing until she falls asleep. Her family history, past medical history, social history were all negative. Her physical exam was unremarkable. She was coughing during the visit, and it's a very specific cough that is typically dry and typically is worse when you're talking about it. Her saturations were normal. Her lung function tests were normal. So what are we going to do with this kid? Refer to speech therapy, yay! So initially she had a post-infectious cough. So obviously if you get pertussis especially, you're going to cough. You get the 100-day cough. And so all of these microbes can cause whether it's a virus or a bacteria, can cause a 100-day cough. Most viruses are going to typically cause 2 to 4 weeks, and so much longer than that is a little bit atypical. What I see all the time is daycareitis, or these kids who are in daycare, they get RSV, and then they're coughing for 4 weeks, and they're getting much better, but then they get rhinovirus before they get completely better. And so they just get these chronic respiratory infections one after another, and they never truly get better in between. So that is very common for me. But they do get better in between, which is the difference. This kid, so coughed for her allowed 100 days from her pertussis, but then just kept coughing. And these post-infectious coughs parents hate them. They have these giant paroxysms. They can puke, and parents hate it when their kids cough and then puke. And so then they come and see me, and I'll be like, yep, kids cough and then they puke, especially if they have a lot of mucus, and then it fills their stomach, and then they're more likely to puke. And they're like, but they're coughing and puking. I was like, I know, I can't fix that. But with COVID last year, we actually did fix it because we didn't see any of these kids. So our medical students and residents had no training in bronchiolitis and these usual respiratory infections. And so it's been an exciting year in children's hospitals where they are currently full, and also have lots of interns and residents and medical students who haven't seen these kind of cases before. Anyway, these post-infectious coughs, like the post-pertussis cough, does not respond to any medications. Nothing's going to make it better, and it lasts for about 100 days, and it should get better. But then there's the habit cough or the leftover cough, and this is where you guys come in. So it is often described as a loud and honking cough, although it can present as a variety of different ways. The kids can replicate it on request, and I'll see a lot of kids who, they'll stare at you right in the eye, and then they let out this horrible sounding honking cough looking straight at you. It's usually non-productive. Nothing else is going on. So they're not having fevers, they're not having weight loss, and they can't go to school. So that's always a big red flag for me that something is going on that is not necessarily pathologic, is that they have trouble going to school. So one of the classic things with habit cough or leftover cough is that sometimes it will happen in specific situations. So whether it's on the weekends when they're at dad's house, or when they're in school, or when they're in math class, or when they're in sports. So a lot of times if you try and tease out the timing, you can find differences there. It completely goes away when you are asleep. So it's not that it doesn't happen at night, it doesn't happen when you are asleep. So it might be really bad before you go to sleep because you're feeling anxious about if you're going to sleep or not. But when you are actually asleep, you do not cough. It can get better with counseling, hypnosis, behavior modification, and speech therapy. There's this really old article from Pediatrics about using a bed sheet. And so it's the power of suggestion. So the kid comes into the clinic, they're coughing, it's a habit cough, completely goes away with sleep. And so what you tell them is that your respiratory muscles are so out of shape from this coughing that you're doing that we need to strengthen them. And so we are gonna wrap you in a bed sheet to help strengthen your muscles, and you need to wear that bed sheet all the time until your cough goes away. And I have never tried this in a patient, but I've always kind of wanted to. So what I do recommend or what I do and how I describe it to them is that you have these cough sensors in your throat, and you were sick, you were coughing, whatever started your trigger, maybe you had bad allergies and a lot of postnasal drip, so something started you coughing, and your body is just so primed to cough, and your cough sensors are so sensitive that we need to calm everything down and break that cycle. So even if you just take a deep breath in, the air going past your cough sensors might tickle them enough such that you start coughing. And so we need to find a way to break the cycle. So what I tell them to do is take sips of water every time you feel like you need to cough. And I tell them to use a water bottle with a sports top, just because that way they're not taking giant sips. It's pretty fast to get it up to your mouth as opposed to having to unscrew the water bottle top. And I say, make an appointment with speech therapy. And if your cough is gone before then, you can cancel the appointment, but otherwise go see speech. And so she went and saw speech for 3 sessions, and her cough got better. So initially, she was coughing because she had pertussis. Then she had the post-infectious cough. It evolved into a leftover habit cough. I told you my take on leftover cough and the cough sensors being super sensitized. I just heard from a local speech therapist yesterday. The way that she describes it is like mosquito bites. And so your cough sensors are like mosquito bites where they're really itchy. And so every time you cough, you're irritating them more and it won't let them go away. As opposed to if you leave it alone and let it calm down, then those mosquito bites will go away, just like your leftover cough will go away. I think all of us are in pediatric pulmonary, have heard of one case where the kid had some kind of mass in their chest, and that was what was causing the coughing. And so getting a chest, I will usually, I don't know that I would say always, but I will typically get a chest x-ray on a lot of these patients just to make sure there's nothing else going on. A lot of the time, they've already had a chest x-ray before they get to me, though. All right, here is a 10-year-old boy. This is the one, I already gave you a preview of him. We saw him yesterday again for his exercise challenge. So he has a history of asthma, takes Flovent 44, 2 puffs twice a day, and albuterol before exercise. Sorry about that. And he has difficulty breathing with exercise. Football is worse than basketball, and especially when it was super smoky outside. He feels like he's clogged in the center of his chest. He describes noisy breathing, difficulty breathing. Takes 20 to 30 minutes for him to start having symptoms. And he was actually kicked off the basketball team because of his noisy breathing. And his dad asked if this could be anxiety related because his breathing is worse when he screws up and the coach yells at him. Poor guy, right? He's only 10. So what are your next steps in the management of this patient? Refer to speech therapy, yay. All right, so I think those are most of the cases that I have for today. We're gonna talk about spirometry really fast because when I was asking around for what I should include in this talk, both speech therapists I talked to said, you need to talk about spirometry. And I was like, really? They wanna know about spirometry? But I am happy to talk about spirometry. So spirometry is a measurement of how much air you can force out. We measure a variety of different things with it, and one of the hardest things with it is coaching the patients through it. And so, like I said, I have this other kid who is so anxious he can't even do the spirometry. Typically, we can start doing it in ages 4 or 5. Girls usually figure it out before boys do, and boys really like to growl into it. I don't really know why. So what you do is you tell them to take a deep breath as big as you can, and then you put the mouthpiece in your mouth, and you blow as hard and fast and as long as you can, and you're coaching the patient throughout the entire test. You want them to blow out for at least 6 seconds, preferably. And it's really a lot like labor and delivery nursing. So this is my mic. So you say, blow, 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 keep going, keep going, keep going, keep going, you gotta keep going, keep going. And it can be very painful standing there next to kids doing it because I find it painful to watch. We use a lot of incentives in the pediatric world, so there'll be bowling pins that it looks like you're knocking down with your breath, or candles that you're blowing out, balloons that you're trying to pop. We have them do it standing. They wear nose clips so that all of the air comes out of their mouth. And we'll see if this video will come up or not. This website doesn't work on Internet Explorer. So we'll try that again. Well, anyway, you can always Google spirometry if you are interested in seeing what it looks like. So here are a couple examples of spirometry. So the things that we measure, the big things that we measure are FVC, or forced vital capacity, and FEV1, or forced expiratory volume in the first second. Oh, now we might have 3 copies of it up in Edge. And we'll see what this comes out. Private video. All right. Thank you, Community Medical Center, for your privacy settings, but we might be able to do it in Chrome. We'll see. So the forced vital capacity, or FVC, is how much total air you blow out. Your FEV1 is the forced expiratory volume in the first second, or how much air you blow out in the first second. So sorry, everyone, no video. Let's go back to our presentation, find our mouse. There we go. And so we get typically 3 different measurements out of each of these. So this is the predicted amount of air that you should get out in your forced vital capacity based on the patient's age, sex, and height, and race. This is what the patient actually blew out in liters. And then this is the percent predicted based on their age, height, and sex, and race. So it is comparing them to 100 other girls of their age and height and race. Those are all the big ones, yeah, sorry. Sometimes we'll do z-scores. The z-scores are a new thing. It's just talking about how many standard deviations away from the mean you are. This report doesn't actually have them on it, and we're not doing them at community right now. So this patient had a forced vital capacity of 112%, so completely normal, had an FEV1, or forced expiratory volume in the first second, of 116%. So kids with asthma, they will typically have a normal forced vital capacity, or FVC, and a low FEV1 because they have trouble. They can get all of their air out, it just takes them longer to get it out. We look at the ratio of those 2 numbers, and so we're looking for something above 80 typically, so this is normal. And then we also look at the loops. So you can see that this loop, this is the expiratory loop. This is the flow in terms of liters per second, and then this is the volume in terms of how many liters they blew out total. So they take a deep breath in, and then they blow out all of their air, and then they take a deep breath in again. Questions about that before we move on to the next spirometry example? All right. So here is another example of spirometry. What you can see here is the loop is very differently shaped. So it's concave is how we describe it, and this is a sign of obstruction. So we see obstruction in diseases like asthma or cystic fibrosis. And the blue line is before we gave the patient albuterol, and the red line is after. So this patient we also gave albuterol to. We have a blue and a red line, but they look exactly the same. We look at the percent change after that, and so we're looking for a 12% change in the FEV1. This patient didn't change. Here's the second patient. Their forced vital capacity, FVC, how much air they blew out, was 111% of what we predicted for their age and height and sex and race. And then FEV1, so how much they blew out in the first second, was 80%, so barely still normal, but way lower than that forced vital capacity, and so we get a ratio of 63, less than 80, so this is considered obstruction. And so what we're looking at is how much of the air did they blow out in the first second compared to how much of the air they blew out total. And then we gave them albuterol, and they went up 18%, so this is what we see with asthma, is reversible airflow obstruction. So reversible because it gets better with albuterol with this red line that is higher than the blue line, and then airflow obstruction because it is concave, the FEV1 is low, the ratio is low. Just a real quick interlude on asthma. So we all have these airways that go down into our lungs where the air sacs are, and we all have muscles on the outside of the airways that respond to our sympathetic and parasympathetic nervous system. In asthma, they have a swelling on the inside of the airways that makes their airway prime to have an asthma attack and also makes it a little bit harder to breathe through this inflamed and swollen tube than it would the normal ones. And then when you have an actual asthma attack, you have lots of mucus, it's even more swollen on the inside, and then the muscles on the outside tighten up and make those airways even smaller and hard to breathe through. Here's another example of a spirometry loop. And so this patient has a flattened inspiratory curve and a very flat expiratory curve, flattened expiratory curve and inspiratory curve. We will see a flattened inspiratory curve with vocal cord dysfunction or indisible laryngeal obstruction if they're having symptoms at the time of spirometry. But you don't typically see the flattened expiratory curve. And so this is a bronchoscopy. The airway lumen is supposed to be over here, and you can see it's this tiny little thing. So this is a patient with subglottic stenosis, and so their airway is tiny. This is an example of an exercise challenge test. So this is what my patient yesterday's exercise challenge test looked like. So what we do is we do spirometry beforehand before they get on the treadmill, and that gives us our or our baseline data. And when you do spirometry, you need to do 3 blows that are within 10% of each other with a maximum of 8 blows. Then after exercise, you do another set of spirometry, and then you keep doing it for every 5 minutes up to 30 minutes, and then you give them albuterol and you see if they get better. So this patient did the maximum number of tests. So we've got 1, 2, 3, 4, 5, 6, 7, 8. So they had to do spirometry 8 separate times. Each time they had to do at least 3 of them. So they're doing at least 24 different spirometry blows. And I don't know if any of you guys have ever done it, but it can make you feel pretty lightheaded. So it's not that much fun to have to do. So this patient had baseline normal lung function, and we made them exercise, and they had no drop in their lung function. So we have this cheat sheet here that says what happens with the forced expiratory volume in the first second, the FEV1, with each of those time points from baseline, and we're looking for a 10% drop. You can also see it on the graph here. So this line is the 10% drop, and so their blows did not make it down to that line. And then at the very end, you give them albuterol just to see if they have a significant response to albuterol. So sometimes we would get patients who would go see cardiology first, and they'd be like, oh, I can't exercise. And so they do this big cardiopulmonary exercise test. And then at the end, they get better with albuterol. And if they just come see us first, then we wouldn't have needed to do all of that. But it definitely happens. Here is another exercise challenge test. This is a positive one, so this one is suggestive of asthma. So started out with normal spirometry and then had a significant drop below that 10% line and then got way better with albuterol. So this is what a positive exercise challenge test for asthma would look like. You can't have asthma and vocal cord dysfunction at the same time, and that can make it pretty tricky in terms of teasing out symptoms. So again, just looking at VCD or ILO versus asthma. So VCD and ILO, you have trouble breathing in. You have stridor, not wheeze. It typically occurs before 10 minutes of exercise. With asthma, it's more difficulty breathing out, and it takes 20 to 30 minutes for you to develop symptoms with exercise, and it's wheeze and not stridor. All right, so here is another case. Here is an 11-year-old male. He has a history of recurrent croup. In November 2020, he had a bad illness. They said it was peripertussis or COVID, and they weren't really sure, and has had a lingering barky cough for a long time. His cough goes away with sleep, and he has normal lung function tests. So what should we do with him? Refer to speech therapy, yay! You can tell that I see a lot of these patients. Here is another kid. So moving on to a different category of of patients, I might be stealing your, oh, no, it's all there, sorry. So 2-year-old male, he's been coughing for months. Mom said, I can't remember when he didn't cough. He does not get worse at nighttime or with exercise. He does cough when he drinks, and he's had 3 hospitalizations for bronchiolitis. On physical exam, he's small, and his exam is otherwise pretty much unremarkable. What are your next steps in the management for this patient? So we're sending him, he's going to be evaluated by feeding therapists, which some places is speech, some is OT, some is both combined. So this kid underwent a video fluoroscopic swallow study. The other way you can do this would be with a FEES or functional endoscopic evaluation of swallowing, where the ENT docs put a scope through the nose, and then the feeding therapists give them something to eat that's blue or drink that's blue, and then they visually watch everything that is going down and see if they're aspirating or not. So this 2-year-old boy showed that he aspirated with thins, and it resolved with thickened feeds. So treatment for these kids who aspirate is to thicken their feeds if there's a safe way to thicken them. Some patients will aspirate everything and have a lot of respiratory morbidity, and so we'll end up doing G-tube feeds. If their aspiration is persistent, they don't outgrow it, as right around 2 years of age, they have major conformational changes in their upper airway, and so they develop this discoordination that will lead to aspiration, and then they outgrow it over time. So if they aren't outgrowing their speech therapy, their aspiration, then having the ear, nose, and throat docs look for a laryngeal cleft that could be contributing to aspiration can be helpful. And then the other thing I'll throw in there is it's really patient-specific depending on the goals of care. And so the right answer as a pulmonologist is I don't want stuff going into the lungs. The right answer as for the family and the patient might be something that's completely different. And so whether it's that thickening feeds, have you guys thickened feeds for anyone ever? Back in training, potentially, even if you're not doing it on a day basis. It's horrible and expensive. And if you're sending kids to daycare, then that's really hard too. And so sometimes I say, because like I said, I see a lot of these 1 and 2-year-olds who present with the chronic cough. And so I'll say, you know, we could do a swallow study and see if they're aspirating, but they've never been in the hospital. Like they're sick and they're coughing a lot, but they're otherwise really fine and they're growing. Then I don't usually want to know the answer, although if the parents are very insistent, I will do the swallow study. Sometimes it's helpful to have the information, even if we aren't going to change their feeding, just so that the family knows, because having that knowledge can be helpful. I'm pretty sure that my now 3-year-old aspirates. He had his ear tubes, and then he was drinking afterwards, and his sats kept going down every time he drank. He also, he was in daycare, and he was sick all the time and had a chronic cough until we took 3 weeks of vacation, and then that was enough time for him to actually get better until he went back in. And then COVID happened, and then he stopped coughing. The other thing I would say is that a lot of the patients that aspirate are patients who are not neurotypical, and so whether it's a progressive disease or a static disease, sometimes feeding is one of the biggest pleasures these kids have. And so even though the right answer for the lungs is that we want to protect them and keep them from getting pneumonia and bronchiectasis over time, and that respiratory morbidity and mortality are significant concerns for these patients, if eating is their biggest pleasure, we have these goals of care discussions with families where the right medical answer might not be the right answer for the patient. So I think about aspiration if kids are coughing, gagging, choking with drinking. If they're not gaining weight well, that's often a trigger for me to want to do the swallow study. And then recurrent respiratory infections, whether they are significant and serious, ending up in hospitalizations, needing oxygen, or that the family is just going so crazy that they feel like they need an answer. You can see silent aspiration, especially in trisomy 21 patients. So in the patients with trisomy 21 who are ending up with lots of pneumonias, definitely thinking about a swallow study is important. And then as I discussed, we will see this in neurotypical toddlers as their upper airway is growing and they are working to catch up to it, and they will just outgrow it after a couple years. So I think the big questions are, when do you do the swallow study? Which swallow study do you do? So video fluoroscopic swallow studies are more widely available than the FEES, the fundoscopic, and the fundoendoscopic evaluation of swallowing. When you don't want to know, so sometimes I don't want the answer. Sometimes it's helpful to do the study because you guys will say, oh yeah, if they do a chin tuck or a hard swallow, or they take a sip of something after they eat, then their swallow is safer. So sometimes we can find safer ways to do it to allow them to continue to have that pleasure. But I think that's always a good thing to ask before you do a test is, what are we going to do with the results of this study? And moving on to another patient. So this is a 9-year-old. This is a 15-year-old male, sorry. So he has giant axonal neuropathy, which is a progressive neuromuscular disorder. He has 2 brothers who are twins who also have the same disease. They are both 13, I believe. He aspirates. Dad has no interest at all in getting a G-tube. He did have a major pneumonia, was in the ICU and intubated, which is when they did the swallow study, was after recovery from that. And so they are doing nectar thickened liquids with the straw. He has to sit up every time he's eating and drinking. He's supposed to take small bites and small sips, minimize distraction so he can just focus on that swallow. But he is going to have progressive decline of his swallow. And aspirating thickener into your lungs is much worse than aspirating thins. And so there again, it's a balance of, are we protecting the lungs, or are we we need to keep a close eye on his swallow and make sure that his nectar thickened isn't getting into his lungs. When do you get a G-tube for him? And I said, it was a very frank discussion about, exactly what I told you guys. The right answer for the lungs might not be the right answer for him, and so we just need to figure out what works right for you and your family, and that can change over time. So right now you might say, this is not worth it to us. We want him to be able to eat and drink. Sometimes it's that, all your liquids are through your tube and you get to eat your solids by mouth, and so there are a lot of different ways that it can shake out. Yeah, this family makes me feel very sad. The other thing about this family is that, so his speech is really difficult to understand. And his brothers, you can understand better, but you know that they're going to lose their speech over time. So let's try pulling up this link. We'll see if it works. Might not. So there, you can't see that screen, huh? Well, let me see if I can pull it up first, and then I will share it with you. And so you guys may be much more familiar with this than I am, but they have these programs of message banking. So there's voice banking and message banking. So voice banking would be banking the sound of someone's voice such that the computer can then generate what they're saying. And then there's also message banking. And let's see if I can pull that up. There's a phenomenal video with this. And I think it's this one. Oh, and you're not going to get any sound. But you get the point, is that this woman has ALS, and so she is sitting there looking at her computer screen. She is looking at the messages on her computer screen. So before she got too far along in her illness, she message banked these things. So she said she had recorded, "Good dog, you're such a good boy." And what you will notice is, so the dog is just sitting there, and then she activates that message, and the dog perks up his ears and comes over to her. And oh, you can't see my screen. Let's try again. What do you see? Is it just blue? I have no idea how to do that. I can send you guys the link for this. Those of you who are online, can you see it on the Zoom? Not sure. Oh, someone answered. Yeah. So the people who are out there in the Zoomverse can see it, and I'm sorry that you guys can't. But there are amazing videos of it's the J. Fishman ALS augmentative communication website. So let's go back to the screen. I don't know what happened. Okay, I don't know what happened. I don't know how we fixed it, but we did. Hopefully the people who are at home can still see. All right, perfect. So with him, I reached out to the speech therapist that he's working with to find out if this would be something that they could work on. So with the 15-year-old, but especially with his younger brothers, who we know are going to be losing their ability to communicate as well. The 15-year-old loves telling jokes, and the mom had to interpret pretty much every single one for me because I just couldn't understand him. The other patients that I thought of that we also share, but I don't have a lot of them. I'm guessing you guys don't have a lot of them. I have somewhere around 10 trached patients. And so there are a variety of places where we overlap there. So with speaking valves or one-way valves, checking transtracheal pressures to see if it's appropriate to be using a speaking valve, feeding issues with patients with trachs where they're more likely to aspirate, either because of their underlying medical conditions or because the trach is changing the configuration of their upper airway. And then a lot of these patients also have developmental issues, and so are needing you guys to help with development from just a prematurity standpoint, and then also with their speech with the trach in place. All right. So the last part of my talk is looking at chronic cough and how we think about it from a medical standpoint. So I gave you cases of patients that we see with habit cough or leftover cough, which is when I refer to you guys. But before I get to that, these are the other things that I think about. So the workup for these patients, somehow that slide didn't make it in here, so sorry. So each of the patients that were included in this giant study from 2009 underwent massive evaluation, so looking for asthma, reflux, allergies, and a gazillion-dollar testing strategy. Some of them had these additional workups done, including video fluoroscopic swallow study. See, I would have done that first before a lot of these other things, but they only did that in some. All of the other patients had bronchoscopies. CT scans, tuberculin skin tests or TB testing, laryngoscopy, alpha-1 antitrypsin testing, and looking at response to immunizations, thinking about an immune system problem. So all of these patients had a chronic cough, so that was on average 18 weeks of coughing. It ranged from 8 to 36 weeks. And one or more causes was found in most of the patients, and in some of the patients, all of the tests were negative. So these are all of the patients that they had looked at. And what I will tell you is that most of these are medical findings. So in these 10% that are normal, are those the kids with habit cough? Were those kids not included in here, or did those kids also have some reflux and allergies going on as well? It's kind of hard to know. So I'm not sure where the habit or leftover cough fits into this picture. But most patients, when they looked at them for why they had chronic cough, most of them had reflux or allergies or asthma or some kind of combination. And so there are often medical reasons for kids to have chronic cough, but a lot of what I see and when I refer to you guys is these kids that have the leftover or the habit cough, that I just need your help breaking them of that. So this was a massive workup that we would never do. I never test the kids for like, do skin testing on their back and then do pulmonary function tests and do a bronchoscopy and put them to sleep. And I never do all of those things in most of these patients because most of the time their history and physical exam tells me what to do. And very rarely is an infection. So when I talk to pediatricians, a lot of times, or especially family docs, a lot of people like to give antibiotics for sinus infections or bronchitis or for some kind of bacterial infection, but in this chronic cough population, very few of them actually had an infectious etiology. All right, so I heard that it's me between you and cocktails. So I know cocktails aren't happening right now, but I wanted to make sure that I did not run over and get in the way of those. I'm happy to answer, unless that is really true. Is it really 4:15? Yeah. Oh, goodness. Whoa, all right. So apparently I talked for, oh, you still have half an hour before cocktails. All right, great. So plenty of time for questions if you guys do have questions. There's one in the chat. Are there differences in findings between races? And the answer is yes. And that is probably because, so that is a very touchy subject these days. There are camps of pulmonologists who think that race should be taken out of the algorithm for looking at lung function tests, and there are those that feel like it is very helpful because of differences in body habitus, and so whether or not the lungs are proportionally bigger in different races or not. And so yes, theoretically there are differences in findings between races. The problem is how do you define race, which is getting trickier and trickier. And so that is a hard question to answer. I don't know if I answered that sufficiently for you, Janet. What other questions do people have? Yeah.
Yes, what's the future research look like? What are they looking at for treatments for the ILO? Is there any new things they're testing?
So for ILO, so there are a couple different breathing strategies that that you guys know better than I do. But so the sniff and the hard shh can help open up the airways, panting like a dog. There are, so at National Jewish, there is a pediatric pulmonologist who will do a continuous laryngoscopy. So the kids will be on, it's a lot of adults actually, he gets referrals from all over. They'll be on a bike, they're wearing a helmet, they have a laryngoscope that goes in their nose and is looking at their vocal cords the entire time that they're exercising. And so they can actually look at the angle of the vocal cords and measure it. And so they can see, before you were exercising, it was at this angle, and now they're not completely closed, but the angle has shifted. And so you are feeling symptoms. We can see that the vocal cords have changed. But in terms of research for strategies to help, I don't actually know. I know that Lori Sloverb, who's the one who invited me here today, so her research is on doing a lot of chronic cough. And so they are looking at ways to help people break that cycle of the leftover cough or habit cough. So there's definitely active research in that. That's a good question. You guys are letting me off easy. Yeah.
So for vocal cord dysfunction or paradoxical vocal movement, is that being replaced with this induced laryngeal obstruction term for across the lifespan, regardless of what induces it?
That's my understanding. And I'm coming to it kicking and screaming if you can't tell. Yeah.
How often when you do flexible bronchoscopy, do you turn and look at the bottom of the vocal cords on your way out?
Never.
Never? Because I did have a patient that had a peduncle polyp that she was choking on and would have this cough only in certain positions, and we couldn't catch it. The speech therapist couldn't catch it with laryngoscopy or video proboscopy, but our pulmonologist caught it on the way out by just peeking on the bottom.
So our scope doesn't flip, so a GI scope has a lot more dexterity to it. Yeah, our scope doesn't, it doesn't go 180 degrees. So I think it would probably depend on what angle you're pulling out with, but that was a fun and find that probably helped her a lot once they found it. What else? Awesome. Cool. Anyone else from the Zoom verse have any questions? All right. Cocktail hour, yay. Well, thank you guys so much for inviting me to speak, and please reach out to me if you have if we have mutual patients or you have any other pediatric pulmonary questions. Thank you guys.